Hello, and welcome to your lecture on endocrine dysfunction in the pediatric patient. There's so many different endocrine dysfunctions that we can review, anywhere from pituitary dysfunction, diabetes insipidus, SIADH. There's a huge list. However, you get the majority of this information in your med-surg classes, and the treatment and management doesn't vary drastically between the adult population and the pediatric population. So today we're going to focus on those endocrine dysfunctions related to pituitary dysfunction and specifically diabetes mellitus as well. So we'll start with what is the endocrine system. The endocrine system controls and regulates metabolism. It's going to regulate your energy, growth, fluid and electrolyte balance, responses to stress, and sexual development. It's regulated primarily via hormones, which is going to be released into the bloodstream and pretty much tell the body what to do, tell your cells what to do. So if you take a look at this, it's a great picture because it really divides up the anterior pituitary and the posterior pituitary and what the two different glands innervate and what they release. So you can see the posterior pituitary is really responsible for the antidiuretic hormone and for oxytocin. And as we've discussed in our maternity area, oxytocin is an important hormone that's related to a lot surrounding childbirth and feeding of the baby. And then if you look at the anterior pituitary, we have your growth hormone, ACTH, TSH, FSH and LH, and MSH, and then prolactin as well. So again, a lot of hormones that are regulating various structures and systems and processes within the body. So the various dysfunctions can be related to structural damage. They can be related to things such as tumors. They can be related to disease processes, or they can be idiopathic and we might not know the cause. And when we're looking at the various disorders, we're going to look at how about what is dysfunctioning, and it's going to vary depending on what is missing and what hormone we are lacking or what hormone we have too much of. So when we're looking at hypopituitary, specifically the growth hormone deficiency, we're going to see various degrees of consequences. And this is really going to be dependent upon how much dysfunction there is in the release of this hormone. So we can see gonadotropin deficiency, which is the absence or regression of secondary sex characteristics. We might see the growth hormone deficiency, which is going to relate to stunted growth. We could potentially see thyroid stimulating hormone deficiency, which we're going to result in hypothyroidism, or the corticotropin deficiency, which is really going to give us some adrenal dysfunction, specifically adrenal hypofunction. So when we have this growth hormone deficiency, we are going to see, again, that stunted growth. So we usually see normal growth over the first year, and then that growth curve starts to slow. And our role in the nursing area is really to determine whether the slowed growth that we're seeing for these little ones is related to a growth hormone deficiency or whether it's related to failure to thrive. So we're going to see these little guys and girls being in less than the third percentile. And how we tell the difference between growth hormone deficiency and failure to thrive is going to be that the growth hormone deficiency are going to be stunted in height, but they're going to grow in girth. So they may appear overweight because everything else is still growing, but they are not growing up. So they're not elongating. And so we're going to want to pay close attention to that. The sexual development will be delayed. However, it will be normal. It won't be abnormal. It'll just be delayed. We're going to look at the family history, at their previous growth patterns, physical examination. What we're really looking to do is to isolate the organic cause. So is this caused by a tumor growth? Is it hypothyroidism? Is it an oversecretion of cortisol? Or what is causing this deficiency of the growth hormone? We're going to want to have really accurate height and weight measurements recorded for all children, because this is the way we're going to be able to tell if their growth curve is changing. So if they're going up beautifully for the first year and then they kind of plateau, it's not the time that they should be plateauing. So if that is the case, then we're going to want to look at some of these other causes that might be there. The endocrine study is really the definitive diagnosis for a growth hormone deficiency. However, it's going to be our last result. We only want to perform these studies on the kids that we are confident have a growth hormone deficiency, and if everything else points here. So we can do radiological surveys, which is going to take a look at this. It's going to have a skeletal survey. If the kids are younger than 3, we'll do a skeletal survey radiologically, or over 3 older kids, we're going to take a look at the ossification in the hand wrist and see what is the size there to determine the bone growth and whether there is a deficiency. The reason why we want to wait on those endocrine studies is because they're fairly invasive and can have a drastic impact on the child. And we'll talk about that a little bit later when we talk about some of the care management. So when we're looking at the therapeutic management, again, we want to hopefully identify the organic cause and fix that organic cause. So if there's a tumor present, we're going to remove the tumor. If we can't fix the organic cause, or we don't identify the organic cause, then we're going to treat with replacement hormones. So the growth hormone will be replaced, and it's very successful. So we have a great success rate with replacing this. We're going to treat until their growth slows to less than 1 inch per year. And it's typically about 14 in girls and 16 in boys. And now this isn't age in years. It could correlate with that, but it's actually bone age that we're looking at here. Now I was talking about those endocrine studies, and this is where, when we do the endocrine studies, a lot of the time insulin is used. Therefore, we're going to see we have the potential for hypoglycemia. Where if we use glucagon, those little ones become very nauseated and are vomiting. And if we use clonidine, then we're going to potentially see some hypotension. So in most of these cases, these little ones are going to need to have an IV present so that we can adequately treat the side effects of the medication that's being utilized for that endocrine study. That's why we want to put those off as long as possible. We're going to be providing support, education, and preparation, as always, with any sort of intervention that we're doing. So when we look at hyperfunction as opposed to hypofunction, so when we have too much growth hormone, what are the effects of having too much growth hormone? Well, this is where we get, for instance, giantism, and we have, if we have excess release of growth hormone before the growth plate closes, then we're going to have longer bones. And you can see here it says that patients can reach a height of 8 feet or more. So these children can grow very tall very quickly. We usually see that weight is proportionate. So we don't have tall, thin people. We have tall, proportionate individuals who have this increase in the growth hormone. So you can think about some of the things that this might affect as well. It's going to put a lot more stress on the heart to be able to pump through the entire body. The body's not meant to be 8 feet tall, and the heart isn't meant to pump to those extensions. So a lot of the time, individuals with pituitary hyperfunction end up having some cardiac problems because the heart isn't meant to do such hard work. So we call this acromegaly, and we're going to see overgrowth in the head, lips, tongue, jaw, nose, the sinuses, and then we might see some separation of the teeth as well. And this acromegaly is actually usually caused by acromegaly is when it's after the epiphyseal closure. So this is when those growth plates have closed already, and then we have a release. So we're not growing bigger. But other areas are growing larger because of that. So the bones are no longer able to grow, but the other areas of the body are. Most of the time, this is caused by a tumor that's releasing the growth hormone, as opposed to just the pituitary hyperfunction of it. It's usually a pituitary tumor that's causing the release of the hormone. So as with any sort of dysfunction, the earlier we catch it, the better the results are. And we're going to treat as much as we can. So some of the things that we can do treatment-wise is we can do surgical interventions. We might do radiation of the tumor itself. Or we might provide hormone replacement depending on what the cause is. We're always going to want to provide emotional support and address the body image concerns that come along with this, and with anybody who is going to end up looking different than what normal is, right? So now we're going to move on to diabetes. So diabetes mellitus has to do with the pancreatic secretion of insulin. And we have two types of diabetes, type 1 and type 2, which we'll get into in just a second. But you can see here that the peak incidence of diabetes is between 10 and 15 years of age, and there's an increased risk for African American and Hispanic children. This is interesting because the risk for type 1 is actually increased for non-Hispanic white children. But because type 2 has become so prevalent, diabetes mellitus as a whole has an increased risk for African American and Hispanic children. Diabetes is going to affect all areas of the body as it affects the uptake of all of the energy producing hormones and substances in the body. So with type 1 diabetes, we have a complete dependence upon insulin. Type 1 and type 2 used to be referred to as insulin-dependent diabetes and non-insulin dependent diabetes. This was changed a few years ago, probably about 20 years ago now, because of the increasing severity of type 2 diabetes and the number of people who are dependent upon insulin with type 2 diabetes. But type 1 diabetes is characterized by an absolute insulin deficiency. So that means that those beta cells are not producing insulin at all. If the onset of diabetes is prior to age 10, then most likely it's going to be type 1 diabetes. There's two types of onset. We have an immune-mediated, so pretty much an autoimmune attack on the beta cells of the pancreas, and we have an idiopathic onset where we just don't know the cause of the type 1 diabetes or of the destruction of those cells. And it is, like I just said, it's more prominent in white children than it is in other races and ethnicities. So for type 2, what we're looking at is an increase, a relative insulin deficiency, a relative insulin deficiency. So we're either going to see insulin resistance with normal secretion. So the cell insulin attaches to the cell wall, which then allows the chemical change in the cell wall to allow blood glucose and other molecules such as proteins and fats and whatnot into the cell. So when we have an insulin resistance, then the receptors on the cell wall are resistant to the insulin attaching to that cell wall. So we can have an insulin resistance with a seemingly normal insulin secretion, but because of the resistance, it becomes relatively deficient. Or we can have deficient rates with a seemingly normal receptor resistance, but because the rates are low, the resistance is, or the amount of insulin that's allowed to attach to those receptors is decreased. So regardless in which case, whether we have the resistance being the main issue or the release being the main issue, we have a relative decrease in the amount of insulin attaching to those insulin receptors on the cells. And we used to see this as an onset after age of 45, and it is still more common after 45, but we are seeing a definite increase in earlier onset and adolescent onset of type 2 diabetes. So why is it important that we have those insulin cells? So like I mentioned earlier, the insulin receptor on the cell membrane, when insulin attaches to that receptor, it allows the cell membrane to open up. So insulin supports the metabolism of carbohydrates, fats, proteins, and by facilitating the entry into the cell. And what's happening when we aren't getting enough of those things into the cell is that the body essentially goes into a state of starvation, which is when we have the glucogenesis, so the breakdown of protein to the conversion of glucose. When we have, when the glucose exceeds the renal threshold, we're going to see glucose in the urine. So that's one of the early signs of diabetes mellitus, especially in children, is glucose in the urine, in addition to polyuria. And the polyuria has to do with the osmotic diversion of water. So because of the glucose concentrations, we get an osmotic diversion of water, which leads to polyuria, which then leads to excessive thirst, which then leads to an imbalance in electrolytes because we're drinking a lot of water and we're spilling all of this out in our urine, and we have the polyuria. So the everything is moving out and very little is staying in. So when we talk about ketoacidosis, we are talking about a state in which the cell isn't able to take in what it needs. So essentially, the glucose isn't available inside the cell, it stays outside the cell. This can lead to cell death, which is going to lead to an increase in potassium because of all the potassium that's in the cells, which can then lead to a cardiac emergency. Ketoacidosis is a dangerous state to be in, especially diabetic ketoacidosis. We're going to consider diabetic ketoacidosis a pediatric emergency because of how quickly these kids can be affected by this. And the treatment is going to include blood glucose, decreasing the blood glucose, so frequent monitoring, the administration of insulin. We're going to administer a lot of fluids and electrolytes because these kids are going to be off-putting a lot of, they're going to have that increased urine, so they're losing a lot of fluid. So we need to institute the fluid and electrolyte. Most of the time, these kids and adults too with diabetic ketoacidosis are going to end up in the ICU. Sorry. So some of the long-term effects and complications of diabetes mellitus are listed here. And we're going to look at the difference between the microvascular and the macrovascular. So the microvascular, as the name implies, is complications related to at the microvascular level. So we're going to see problems with the kidneys, problems with the eyes, those areas that have that microvasculature, mostly due to the lack of blood flow to those areas. And it's described well when you think about it from a macrovascular perspective, but it's the same concept. So what happens is you get this buildup of proteins inside the vessel walls, and then those vessel walls become sticky, and so blood isn't able to flow. And you can think about the microvascular areas where the vasculature becomes so small that any buildup is going to have an impact. You can kind of think about it the same way as cholesterol and as fat builds up in like the coronary arteries. It's a similar concept, and it just affects the blood flow. So we get death of the tissues at the end of those vascular innervations. The neuropathy is the same thing. So we get not enough blood flow to those areas, and it causes a neuropathy. With poor control, you can see this as quickly as 2 to 3 years into having the disease. And with excellent control, it can be delayed 20 or more years. Some people are able to really control their blood glucose and are able to maintain adequate blood flow and not see these complications till much further into life. Some of the other complications that can occur are hypertension and atherosclerotic cardiovascular disease. So how are we going to diagnose diabetes? We're going to first be on the lookout for our risk factors. And our type 1 risk factors are going to include genetics and any autoimmune disease. So if a current autoimmune disease, they're going to have a higher risk of having diabetes. And if we have a genetic component, then there's a higher risk. We are going to look for that glucosuria, the polyuria, and then here is listed the different tests that are done to confirm diabetes. So you can see the 8-hour fasting blood glucose of 126 or above, a random blood glucose of 200 or above, and then an oral glucose tolerance test. The hemoglobin A1C of 6.5% or more is really going to be the gold standard because that gives us the blood glucose control over the past 2 to 3 months. So if that A1C is above 6.5%, then we're gonna see that there is some issues going on. So what are we going to do for these guys? So lifestyle change is going to be number one, especially with type 1 diabetes. It is going to impact every single aspect of their lives. And if you remember watching that video, or if you haven't watched it yet, when you watch the video, you will see the little girl who has type 1 diabetes and how frequently she is taking her blood glucose and how impactful the blood glucose and the administration of insulin, and being cognitively aware of that is important. The insulin needs change with the child from day to day. So emotions can affect the insulin needs, the child's activity level for the day. If the child's ill, it's not just what they eat that has an impact on that. So keeping that in mind is very important when educating the parents and the children about this, and when caring for these patients, because realizing that everything we do to them could potentially impact their insulin needs is a good it's a good mental check for us. When we look at how to dose the insulin, it's going to be determined by the blood glucose level. So some of the insulin can be administered via pump, and sometimes all of the insulin can be administered via a pump. But the blood glucose level is going to determine what amount of insulin is administered. Typically, when the pump is present, these kids are receiving a basal rate of insulin, and then they give themselves boluses through the pump based off their finger prick, not based off their serum blood glucose level that an internal device might give them, but based off of a finger prick before meals to give that bolus. So the pumps can be great. They just need adults and children who are highly committed. And as the video shows, that there is quite a bit of mathematics that goes along with the calculations to determine how much insulin to give on top of that basal rate. Box 47.14 gives you some great information on the various types of insulin. You don't necessarily need to know that for my tests. However, it's very important to have a good understanding of the different insulins and the rapid acting versus intermediate versus long acting insulins, and when you would give each, and how they are administered. For monitoring, we're going to want to look at the blood glucose levels. So again, that finger prick, this is going to be the standard monitoring that happens on a daily basis. The A1C, which is the glycosylated hemoglobin, is going to be every couple months that we take that, just to see how that blood glucose control is going. So again, this gives us a good indication of the control for the past 2 to 3 months. So overall control. So this will be an important benchmark for the child along the way, but it doesn't give us treatment goals on a daily basis. Urine used to be a good way to determine whether you were in good control or not, but now we don't utilize the urine test to determine the control of the diabetes. The only time the urine test is helpful is to test for the presence of ketones, specifically during an increase in blood glucose. So if the child gets a high test, say above 230, I think it is, or if the child's ill, then we'll want to test for ketones, because the consumption, the insulin consumption is so much greater during those times. So nutrition is going to be important, and more along the lines of seeing of what they're eating when. So we want to decrease the sugar, decrease the fat, and increase the fiber that these kids eat. So that's going to be about 30% of the diet. And decreasing sugar is always good for everybody, right? And the fiber is really going to help to control the blood glucose after meals. We want to really, sorry. We really want to stress the importance of the timing of eating, that the consistency or the timing is consistent across the day and from day to day. And we want to make sure that these little kids understand that they need to eat snacks as well, because that insulin is going to peak and their blood glucose is going to go down. So it's important to have 3 meals and 2 snacks between meals, and probably a bedtime snack for most individuals as well, to keep that standard level of blood glucose circulating throughout the body to be utilized, or to be utilized by the insulin as well. So education, again, is where we're going to be, and we want the kids to record what they're eating, so that if there's any issues, we can look back and see, well, maybe this wasn't the best choice, or, oh, look, today you ate your breakfast at 10 a.m. So of course you were hypoglycemic at 8, since you woke up at 6 and didn't eat till 10. So those types of things can be really helpful if we have that record. For exercise, we want to encourage exercise with type 1 diabetes, just like any other type of, or just like any other child. And type 2 exercise is going to be key. And type 2 nutrition is key. But in type 1, with the exercise, we are going to educate these families that they're going to need to adjust their food based off of how much exercise. So the more they exercise, the more food they're going to need to eat. And we really don't want type 1 diabetics controlling their blood glucose with food restriction. And by that, I mean amount of food eating. So these children should be able to eat until they are full. Type 2, we might want to introduce some food restriction. What are we going to do in cases of hypoglycemia? So I kind of mentioned the morning hypoglycemia. It's going to be important to eat when they wake up. But in other areas, or in any instance, I guess, of hypoglycemia that is symptomatic, we're going to want these kids to eat a simple carb, and literally a spoonful of sugar is going to be the best way to have the body rapidly absorb some glucose and get it into the blood. So we're going to give a simple sugar or a simple carb, we're going to follow that with a complex carb and some protein. So for instance, we could give a spoonful of sugar and follow it with a piece of bread with some peanut butter on it. And that's going to give them that longer lasting control and that longer lasting blood glucose than just the simple sugar. But the simple sugar is important for that immediate fix that we're going to see. And when we're looking at hyper versus hypoglycemia in the acute phase is going to be more detrimental than hyperglycemia. And if you look at the box in the book, I think it's, I'll tell you later what the box it is, but you have a great box in your book that tells you which the various signs and symptoms of hyper versus hypoglycemia. And you'll see that they're very similar in most cases. So it's best to treat with sugar and to relieve that hypoglycemia than to let that go. So it's going to be really good for the hypoglycemia to give the sugar, and it's not going to do too much harm if it is hyperglycemia. So we're going to treat, and then as we're getting a blood glucose, because that's really going to be our definitive test to determine what to do. Again, the illness management, we're going to closely monitor the ketones in the urine. We're going to closely monitor the blood glucose to ensure that these kids are getting enough sugar and enough insulin to correlate with what they need during the illness. And we've talked about diabetic ketoacidosis, but just to reiterate, it is a pediatric emergency, and it is something that we're going to want to refer to an ICU or higher level of care if it is suspected. So here's just a little picture of a school-age kid. You can tell this was the 80s, early 90s, before the fabulous insulin pumps were readily available. But school-age kids can give themselves their injections. They can administer their own their own glucose, their own insulin, and they can take their own blood glucose. We're going to want to educate these children and their parents to keep their supplies with them at all times. They're going to want to have glucose tabs. They're going to want to have extra insulin, needles, their blood glucose monitor, and have those readily available at all times. The glucose tabs are of utmost importance. And again, most kids now have a pump, which is great and a great way to administer it. However, it is still a machine which can have errors, so we want those backup supplies available as well. This is a big change in a child's life to be diagnosed with type 1 diabetes and in the entire family's life. So there's going to be a major element of interprofessional care management that occurs. Everybody's going to be involved. So the teacher at school is going to need to know this. The parents are going to want a direct communication with that teacher. You know, my husband has one type 1 diabetic in his 5th grade class right now, and he has had previous type 1 diabetics, and those parents have his personal phone number, which most parents don't, and they text him on a regular basis. So having that open line of communication with the teacher to ensure that the child's doing well throughout the day is great. And with the coach and the school nurse becomes very involved with these kids. Coaches, obviously, if the child is involved in sports or other athletics, then it's going to be important for the coach to be involved and be aware of what's going on, especially if the parent isn't always present. And anytime the child is hospitalized, then we're going to have a variety of different interprofessional groups involved in the care of this child. So the diabetes, depending on whether we have type 1 or type 2 that we are dealing with, it's going to impact how the child is cared for and the various planning that needs to go into it. Again, type 1 diabetes is typically what we're going to be seeing in children, but type 2 is on the rise. So we need to be aware of the risks for type 2 so we can educate. We need to be aware of what we're looking out for, and we need to be aware of the complications these kids can incur who have type 2 diabetes in addition to type 1. Meal planning is going to be really important for these kids. They can't just, meals can't just be on the fly like they are so often these days in many families, because they have to eat at a certain period of time, and not too much time can go between having a meal. That's why those snacks are so important. So you can imagine the impact that's going to have on the family and on travel and on holidays and staying over at friends' houses, and just anything that this child does. They need to think ahead and have things planned out beforehand. When we're looking at monitoring, we talked about this a little bit already, but the urine testing isn't really something we do too much anymore, other than to look for the ketones in situations of illness or high blood glucose levels. And I'll tell you the table. So table 70, I'm sorry, not 70, 47.3. Table 47.3 gives you a side-by-side comparison of the signs of hyperglycemia compared to hypoglycemia. So you can see some of the differences, but you can see also how they manifest very similarly. Hygiene is going to be very important. There's an increased risk for yeast infections, especially in girls with diabetes, in addition to the hygiene that goes along with the actual finger pricks and injections and utilizing the pumps. And we talked about record keeping and how important that is. not only for like a food journal, but also recording the various blood glucose levels. And that's where some of these pumps and the smartphones are fabulous, because they have great apps that can really show the trends and give a really good graph and good understanding of where the child's blood glucose levels have been, what their insulin consumption has been, and that can really help their management team, their care management team, make decisions for future care for them. Family support is really going to be huge. As with any childhood illness, type 1 diabetes is no different. It impacts the entire family. And these parents are now responsible for, again, planning out the meals for this child, having supplies on hand, making sure that everybody or everybody who cares for this child in one way, shape, or form has an understanding of the disease. So our role in providing education to the parents so they can then educate others is of vital importance. I think that is it. So hope you enjoyed pituitary dysfunctions and diabetes mellitus, and I will see you soon.